Good morning. It's Tuesday morning, the second Tuesday of March, and this is a small video. I've had a couple of requests to talk about rheumatoid lung disease. So here we are to talk about rheumatoid lung disease on Dr. Steve TV. Again, as always, if I'm in the car, I apologize for any distractions, and I am in the car. So, first of all, rheumatoid arthritis, please understand, it's a multi-organ, multi-system disease with a predilection to the small joints in a symmetric pattern, and it is mostly the PIPs and MCPs, and it does spare the DIPs. In fact, when I was in my training, Ralph Schumacher, my teacher, or one of my teachers, told me that if I ever said rheumatoid arthritis occurred in the DIPs, I should not acknowledge that he was my teacher. So, for what that's worth. So, you're talking PIPs, MCPs, and wrist. However, I've seen it present as monoarthritis, which means one joint. I've seen it present in one small joint. I've seen it present in one large joint. I've seen it present in an oligoarticular pattern, and so on. We have the benefit of the CCP antibody if the level is greater than 250 with an elevated rheumatoid factor, and you've excluded other causes of positive rheumatoid factor, then you're left with a diagnosis of RA. And if you treat them with anti-inflammatories and an appropriate constellation of various medicines, the patients generally do well. Poor prognostic indicators which leads into lung disease include very, very high rheumatoid factors, chronic untreated disease, severe deformities, concurrent smoking, and others. So, if we talk about rheumatoid lung disease, the most common lung manifestation would be pleurisy. Pleurisy means there's inflammation of the pleural lining, not exactly in the lung. However, we're talking about inflammation of the lining of the lung. This is when you get typically pain with a deep breath. It's often treated by increasing the current treatment the patient is already getting, some steroids, some NSAIDs, even though the cardiologists tend to use colchicine when they have serositis. And by the way, serositis means inflammation of a serosal membrane, which includes the pleura, the pericardium, and the abdominal cavity. But we in rheumatology are not buying into this colchicine stuff in our diseases. So pleurisy is the number one manifestation, or what we call extra-articular manifestation. It means manifestation of rheumatoid arthritis not involving the joints. So then we have interstitial lung disease. Interstitial lung disease, that's no longer the pleura, which is the lining of the lung. The interstitium is within the lung. So within the lung, we have a creative system where the oxygen comes in. Oh, sorry, the car's accelerating. Luckily, by the way, I'm not driving. If I made this video while I was driving, you'd probably see me wrapped around a tree right now. But, so the interstitium is the lung tissue itself, and various things can happen. So the interstitium gets inflamed, and if you treat the inflammation rapidly and aggressively, you can shut down the inflammation. If not, people go on to get scarring and hidebound lung, or like a leather lung or a cardboard lung, just a lung that doesn't work. And they have all kinds of shortness of breath, and ultimately that leads to right-sided heart failure, and they have a very poor outcome. And then another one for rheumatoid lung disease would be rheumatoid nodulosis, or nodules. So you've seen every now and again a person who's got a large golf ball size lesion on their elbow, and this is typically called an olecranon nodule because that's the olecranon region, And when the nodule is in the region, if it's soft and fluctuant, we call it bursitis, because that area of the olecranon is actually a bursa. You can Google bursa, it's not important for right now. So rheumatoid nodules in the lungs are very common. One of the most important things I can emphasize, if you have a rheumatoid arthritis patient with lung nodules, generally they're going to be asymptomatic. They're not going to know they have the nodules. An exception would be if a nodule were to rupture or get necrotic, the person would have shortness of breath and probably hemoptysis, or coughing up blood or blood from the lungs. So the nodules have to be followed. You want to make sure they're not growing. You want to make sure there's not a new nodule, because frankly, if you've got a patient with stable rheumatoid nodules in their lungs and they develop a new nodule, you have to assume the new nodule is a cancer, and you have to treat it as such, whether it be biopsy or PET scan. You cannot just assume because somebody has rheumatoid nodules that the next nodule is going to be another rheumatoid nodule. There are other there's other rheumatologic manifestations within the lung, or extra-articular RA involving the lung. And we could have this discussion for the heart or other organs, but the lung is a common one. In fact, the number one extra-articular manifestation of rheumatoid arthritis is rheumatoid nodulosis, so nodules. And I mentioned high rheumatoid factor as being a bad prognostic indicator for worse disease. Another bad prognostic indicator for worse disease happens to be rheumatoid nodules. And this would really include skin nodules and elbow nodules. But rheumatoid lung nodules fall under the same category. There is a lung condition in rheumatoid patients, and the name slips my mind. It's been 30 years since I've even heard about it, but it's interstitial lung disease in a person who works with the wrong exposure that will develop another type of rheumatoid lung disease. There are other rare features of rheumatoid lung disease, such the car's bouncing around. When you get these $2 taxi cabs, they're just too bouncy. It's no good. But other things, apical bullous nodules, typically not seen in RA, but I've seen them once or twice back in training. The neat thing about training is you see everything, and if you don't know what it is, somehow it gets labeled to be part of that disease. I hope this was helpful. I know a couple of you have asked me to elaborate on rheumatoid lung disease. Enjoy the rest of your Tuesday, and as always, if there's any questions, comments, concerns, if you want to share this information, if you want other people to subscribe so they can learn accurate information about their condition, please have them subscribe to Stephen Soloway. That's Stephen with a PH, Soloway. And for our purposes, this is Dr. Steve TV. It's kind of like a documentary. Anyway, maybe I'm running out of words. Have a great day. Enjoy.